Bom, boa noite a todos. Nós vamos dar início ao nosso Grand Round hoje, em conjunto com a Duke University. Então, como a gente sempre tem esses Grand Rounds em conjunto, o primeiro caso nosso vai ser em português, e a partir o segundo caso vai ser em inglês, e depois nós temos os casos da University, da Duke University, ok? Então, vamos lá, Mirella?
Vamos sim. Boa noite a todos, eu sou Mirella, residente do segundo ano. Irei apresentar um caso do setor de vias lacrimais sobre a orientação da doutora Simone Bison, que também é a chefe do setor de vias lacrimais. Um momento. Agora. O caso é sobre uma paciente do sexo feminino de 66 anos, natural e procedente de São Paulo. Ela chegou ao nosso serviço com a queixa de epífora sem secreção mucopurulenta em ambos os olhos há cerca de 2 anos. De antecedentes pessoais, referia diabetes mellitus, controlada com medicações por via oral. E de antecedentes oculares, referia 4 cirurgias prévias realizadas nas vias lacrimais externamente. Ela trazia um longo histórico, começando em maio de 2019, onde ela trazia uma dacrocistografia que demonstrava uma obstrução incompleta bilateral, especialmente do canalículo comum, bilateralmente, e do ponto lacrimal inferior esquerdo. Dessa forma, foi realizada uma dacrocitorrinostomia externa com implante de tubo de silicone Silastic no canalículo inferior. Entretanto, a paciente manteve os sintomas, principalmente no olho esquerdo, em 2020 foi submetida a uma nova cirurgia, que foi a dacrocitorrinostomia, desta vez por via nasal, também com implante de tubo de silicone. Porém, depois de 1 mês da cirurgia, houve uma extrusão espontânea do tubo. E ela trazia uma dacrocistocintilografia que foi realizada depois dessa segunda cirurgia. A dacrocistocintilografia é um exame funcional da via lacrimal, um exame não anatômico, que é realizado após a administração de tecnésio no fundo de saco lacrimal. Aqui as imagens, após a primeira instilação, que é essa que aparece como pré-estímulo, que a gente já consegue ver que o radiotraçador migrou do lado direito, tanto para o saco como do lacrimal, e do lado esquerdo apenas para o saco lacrimal em menor intensidade. E após uma nova instilação, do lado direito a gente vê que a via está pévia funcionando e do lado esquerdo demonstra uma obstrução parcial. Em seguida, a paciente fez a terceira cirurgia, que foi justamente após a extrusão do tubo, que foi a nova colocação do tubo, um novo Silastic. E, por último, e depois dessa cirurgia, ela tem uma dacrocistografia de ambos os olhos, demonstrando uma via lacrimal pérvia. Entretanto, em janeiro deste ano, a paciente foi submetida a uma 4ª cirurgia porque mantinha os sintomas bilateralmente. Ela fez uma dacrocitorrinostomia externa, também com implante de tubo de silicone, com melhora completa do lado direito, sem sintoma de epífora, lacrimejamento, porém, no olho esquerdo, ela referia que mantinha uma epífora severa. Em fevereiro de 2020, foi realizado também no serviço externo uma tentativa de melhorar esses sintomas do lado esquerdo com injeção de toxina botulínica na glândula lacrimal esquerda. Entretanto, posterior a essa aplicação, a paciente evoluiu com diplopia e ptose e mantinha os sintomas, mas essa diplopia e ptose houve melhora espontânea ao longo dos meses. Eu vou mostrar o exame de entrada da paciente no serviço. O exame oftalmológico, a acuidade visual no olho direito era de 20/20, no olho esquerdo também de 20/20. Na biomicroscopia anterior de ambos os olhos, a paciente tinha pálpebras e cílios sem alterações, conjuntiva clara, córnea transparente, câmara anterior formada, sem reação de câmara, íris trófica, a paciente era fáscico. A pressão intraocular de ambos os olhos era de 16 e a fundoscopia de ambos os olhos também não tinham alterações. Disco óptico rosa, bem delimitado, escavação fisiológica, vasos e máculas sem alterações e retina aplicada. Eu vou mostrar fotos a seguir da propedêutica específica das vias lacrimais, começando pela avaliação dos pontos lacrimais. Não sei se a doutora Niva quer que eu descreva ou quer abrir para...
Hoje eu vou querer que você descreva, Mirella.
Perfeito, perfeito. Começando com a avaliação dos pontos lacrimais do olho direito, os pontos eram presentes e de contorno regular. Na avaliação do Milder, que é justamente o teste do desaparecimento da fluoresceína, após 5 minutos do olho direito, a paciente tinha um Milder de 1. E na avaliação dos pontos lacrimais do olho esquerdo, eu sei que pela foto é difícil avaliar, mas o ponto lacrimal superior era presente, mas irregular, e o ponto lacrimal inferior também era irregular, com aspecto de laceração, que é justamente o ponto lacrimal que ela colocou vários silastiques, houve extrusão, tudo isso. E o Milder desse olho, ela tinha um Milder de 2. Aqui, resumindo, a propedêutica específica das vias lacrimais, do ponto lacrimal e do Milder, que eu já fiz, que eu já falei, e na sondagem do olho direito, pelo canalículo superior, tinha um hard stop, do canalículo inferior, tinha um soft stop. E do olho esquerdo, tanto na sondagem superior e inferior, o paciente apresentava um soft stop a cerca de 5 milímetros do ponto lacrimal. E na irrigação do olho direito, pelo canalículo superior, já era positivo, e do olho esquerdo, tanto pelo canalículo superior, tanto quanto pelo canalículo inferior, havia refluxo na irrigação. Prosseguir com as hipóteses?
Agora, nas hipóteses, eu vou chamar o Guilherme, já que eu sei que você está aí, você não quer fazer as hipóteses diagnósticas para mim, por favor?
Sim, então, boa noite. Temos uma paciente de 66 anos, né, sexo feminino, que tem uma queixa de lacrimejamento no olho esquerdo, mesmo após múltiplas cirurgias, né? Com a propedêutica das vias lacrimais do olho esquerdo, a gente pode concluir que ela tem um quadro de obstrução, né, tanto pelo Milder, tanto pelo refluxo, a irrigação, e como ela apresenta soft stop na sondagem, eu classificaria como uma obstrução alta das vias lacrimais no olho esquerdo.
Exatamente, perfeito. Uma obstrução alta, poderia pensar em topografia canalicular, justamente. E para a conduta, neste caso?
Gustavo, sabe?
Deixa eu ligar meu som. Tá. Então, boa noite. Então, pensando nesse caso, para uma obstrução alta de vias lacrimais unilateral, uma paciente que já sofreu múltiplas abordagens, evidentemente essa paciente teria que repensar numa conduta cirúrgica, e para isso precisaria estudar melhor a topografia, né, a anatomia das vias lacrimais, solicitaria uma dacrocistografia de início para poder planejar melhor a cirurgia e preparar o planejamento de acordo com o exame.
Exatamente. Foi realizado, então, a dacrocistografia. Vou mostrar a foto primeiro do lado direito. O contraste iodado é injetado tanto pelo ponto lacrimal superior quanto inferior. Nas fotos superiores são a injeção pelo ponto lacrimal inferior e nas fotos inferiores é a injeção pelo ponto lacrimal superior. E demonstra por essas imagens que houve a pacificação parcial do saco lacrimal, sem progressão do contraste para os ductos lacrimais, mas, porém, houve absorção desse contraste pelas células etimoidais, concluindo assim que houve um preenchimento parcial do saco lacrimal à direita. E do lado esquerdo, mesmo após a injeção do contraste pelos orifícios, tanto superior quanto inferior, não resultou na opacificação do saco lacrimal deste lado, mesmo quando houve aumento da pressão na seringa, o que pode decorrer justamente de uma obstrução ou estenose acentuada da via lacrimal alta, que é justamente a conclusão deste exame. Então, como conduta, foi indicado uma conjuntiva dacrocisto-rinostomia por via endonasal da via lacrimal esquerda com implante de tubo de Jones-Lester. Eu vou mostrar a seguir o vídeo da cirurgia. Deixa eu dar play. A cirurgia é realizada em conjunto com o otorrinolaringologista. Como vocês podem ver nesse vídeo, primeiramente, sob visualização endoscópica por via nasal, foi realizada a tubinectomia parcial, em que as estruturas da concha nasal são removidas parcialmente. E, neste caso, foi feita a ressecção da cabeça da concha média. Como vocês podem ver nesse vídeo, é feita a ressecção e é retirado essas estruturas. Em seguida, vocês vão ver que através da carúncula é criado o caminho por onde o tubo irá passar. Um catéter endovenoso de 16 gauges inserido na região caruncular em direção à cavidade nasal, com visualização direta, claro, por onde esse endoscópio irá entrar na cavidade nasal. Em seguida, que vocês vão ver mais à frente, é medida o tamanho que será o tubo. Neste caso, foi escolhido um tubo de 16 milímetros. Em seguida, é feito o mesmo percurso, sendo que no sentido contrário, com um gancho, a fim de garantir que não haja um duplo trajeto. E esse trajeto também é confirmado fazendo simultaneamente o caminho cavidade nasal carúncula e o caminho carúncula-cavidade nasal com os dois instrumentos ao mesmo tempo para garantir que haja um pertuito adequado para a passagem do tubo. A seguir, vocês vão observar essa pinça que é feito o polimento do trajeto por onde o tubo irá passar, utilizando um estilete para algodão grosso. Essa pinça anterior que lembra um parafuso. Em seguida, o tubo é inserido utilizando com auxílio de um guia metálico, sob visualização direta de onde o tubo irá ficar. Após a inserção do tubo, esse tubo é testado o fluxo através do tubo e, posteriormente, ele será fixado. Vocês vão ver a seguir, observando a posição externa do tubo, já com a fixação. E observando também o fluxo através do tubo de drenagem, o tubo de Jones. Vou mostrar a seguir imagens do pós-operatório. No sétimo pós-operatório, o paciente apresentava um olho calmo, o tubo apresentava-se funcionando corretamente, com melhora do míodo e dos sintomas de epífora da paciente. Que imagens do 15º e do 30º pós-operatório. E eu vou demonstrar também um vídeo com 4 semanas de pós-operatório, onde a gente pode observar a posição correta do tubo de Jones, tanto por via externa quanto por via endonasal, mostrando o seu funcionamento e posição correta. E é isso. Obrigada.
Muito, muito bonito o caso, Mirella, Simone, parabéns, porque não é a gente não costuma observar esse tipo de conduta aqui no Graham, né? Então, parabéns. Simone, você quer comentar? E é interessante da gente aprender com esses casos, o que teria feito diferente a primeira e a segunda eu acho que tudo bem, mas e na terceira e na quarta cirurgia, o que a gente poderia ter feito diferente? Você poderia comentar, por favor, Simone?
Bom, primeiro, parabéns para a Mirella. Vocês estão me ouvindo bem?
Sim.
Dá para ouvir?
Sim.
Sim. A Mirella se empenhou na montagem do caso, porque era muita coisa, e ela assimilou todo o raciocínio em relação à propedêutica, às cirurgias. Então, parabéns, Mirella, já fica aí você de candidata às vias lacrimais no futuro aí. Bom, essa paciente, ela tinha muito medo de colocar o tubo de Jones, tá? Então, ela veio no meu consultório, ela tinha passado por 4 oftalmologistas diferentes, cada vez operando. Aliás, 2 dessas cirurgias foram com otorrino e não com oftalmo. Inclusive as 2 primeiras, que eu acho que é aí que a coisa não deu muito certo. porque ela tinha, desde o começo, um certo problema de estenose canalicular, e eu creio que essa perda do tubo que ela falava que tinha nas primeiras cirurgias, é porque a passagem do tubo era tão forçada e que o silicone ele é muito delicado, eu acho que ele ficava trincado e ela acabava perdendo o silicone no pós-operatório. Então, essa é a minha impressão. É por isso que cada vez mais nós temos tentado trabalhar em otorrino e oftalmo, porque, assim, o domínio do nariz é melhor para o otorrino e o domínio dos canalículos é melhor para o oftalmo. Então, principalmente em casos difíceis assim, o oftalmo dilatar bem os canalículos, passar o silicone, faz toda a diferença, porque eles têm medo de manipular o canalículo, tá? A última cirurgia dela eu já não teria feito por via externa, e a aplicação de toxina botulínica da colega já foi um ato de desespero, porque ela já não sabia o que fazer com a paciente, tá? Então, assim, as canaliculopatias estenosantes, essas pós-virose, pós alguns medicamentos, como quimioterápicos, radioterapia, radiodo, esses pacientes têm uma resposta meio inesperada aí no resultado. Eles, ao invés de funcionar como ampliação, acaba funcionando com estenose no pós-operatório, com fibrose no pós-operatório. Então, essa paciente, o que teria feito de diferente? Deixar o silicone bastante tempo, quando é possível, e o antimitótico, a mitomicina C, é um pouco debatido, há um certo conflito de quem é a favor ou é contra, eu não uso de rotina, mas se fosse minha terceira cirurgia, com certeza eu teria colocado mitomicina C ali no ósteo cirúrgico no nariz, tá? É o que teria para fazer. Deixar o corticóide um pouquinho mais de tempo, tirar muita crosta do nariz, a gente sabe isso também, que grande parte das recidivas, vamos pensar num caso normal de dácrio, vai, porque ela não foi normal desde o começo. Grande parte das recidivas, nós sabemos que é porque no pós-operatório forma muita crosta ali no nariz, e aquela fibrina na saída do ósseo vai favorecendo a retração cirúrgica ali do que foi feito. E tubo de Jones, quando chega a segunda, terceira, quarta cirurgia, essa paciente mesmo, ela chegou para mim já com pré-operatório, para só marcar a data da cirurgia. Ai, doutora, não dá para pôr aquele tubinho? Eu falei, se for para pôr o tubinho, o outro, de silicone, a senhora vai em outro, porque não vai ser comigo. Aí ela tomou um susto, né? Eu falei assim, não, porque de não resolver, a senhora já tem 4 cirurgias. Eu falei, a gente tem que fazer para resolver isso de vez. E ela está super feliz. Essa paciente agora está com pós de alguns meses, ela está bem satisfeita, tá bem feliz.
Parabéns, Simone, caso fantástico, adorei, Mirella, Simone foi muito bem. Então, agora eu vou passar...
Eu tenho uma pergunta.
Pois não.
Posso?
Oi, chefe.
Então, é assim, eu vou passar para você, depois você já conduz, tá bom? Você faz a pergunta, depois já muda para a norma, ok?
Mas não é Duke na próxima? Já é Duke?
Não, é o nosso, mas vai ser tudo em inglês, aí a gente já muda a língua.
Ótimo. Simone?
Oi.
Aquelas coisas que vêm sempre um acompanhado do outro, né, caso diferente. Eu tive 2 casos seguidos nas últimas semanas de obstrução do canalículo acreditada pela médica que encaminhou ser pelos colírios de glaucoma. Uma delas resolveu com a suspensão e com o uso de corticoide, e a outra a gente está tentando ver o que fazer. Você tem visto isso?
Tenho. Os análogos da prostaglandina, principalmente. E já tive até com maleato de timolol. Isso que você falou, de suspender o medicamento, dar um pouquinho de corticoide, porque eu falei, nossa, timolol não é para dar muita reação, né? Mas eu já tive também, tá? Então, qualquer sensibilidade à droga, os conservantes, pode dar um processo inflamatório dentro do canalículo, né? Então, às vezes não é nem a droga, é o conservante.
Isso quer dizer, tem muito do cloreto mesocônio também, né?
Sim, sim, sim. Então, tem sido frequente, sim.
2
Tá
casos
certo
seguidos,
que eu acabo absorvendo os casos, né? Então, obstrução alta ninguém gosta de tratar, então eu acabo encaminhando para mim, mas assim, pós-viral e pós-drogas tem sido mais frequente no consultório, mais que trauma. Meu consultório, raramente eu tenho um trauma. Tá?
Eu encaminhei os 2 casos também.
Não, você faz o tubo de Jones. Tá, joia.
Tá, joia. Obrigado.
Muito bem, obrigada.
Então, a gente passa para a Norma, né?
Good evening. Tonight we are welcoming our colleagues from Duke University. But first we are going to present a case report in Strabismus. The resident will be Dr. Macedo, and the preceptor is Dr. Plut. Guilherme, you can begin.
And good evening. I'm Guilherme Macedo, second year resident. I'm going to present a case from our Strabismus division. My preceptor was Dr. Mauro Plut, and the head of the division is Dr. Simone Nakayama. So we have a 31-year-old male patient, salesman, born and raised in São Paulo, who attended our emergency room complaining of a blunt ocular trauma in the left eye, a punch, one day before during a robbery attempt. He referred daily use of cocaine and low vision in the left eye since childhood due to toxoplasma retinochoroiditis. So he presented a visual acuity of 20/20 in the right eye and counting fingers in the left eye. I'll show the pictures of dactyloscopy and the oculomaxillary exam and describe the anterior microscopy with the pictures. The intraocular pressure was 12, both eyes. Fundoscopy of the right eye presented pink cup to disc with sharp margins, cup to disc ratio of 0.4, normal macula, normal vessels in attached retina. In the left eye, he presented a pink cup to disc with sharp margins, cup to disc ratio of 0.7, a macular scar, normal vessels in attached retina. So here we have dactyloscopy.
I think you can go on, please.
Okay. So we have the first picture, mild proptosis of the left eye. The second picture, we can see a normal exam of the right eye. And in the left eye, the patient presents mild, this periorbital edema, periorbital ecchymosis, this extensive subconjunctival hemorrhage with this conjunctival laceration here in yellow. But the cornea and sclera were intact. So we have a clear cornea with a deep anterior chamber, symmetric with the right eye, without reaction, trophic iris, and clear lens. Here in the oculomaxillary exam, the patient presents the left eye presenting abduction in all gazes. He was unable to perform adduction of the left eye, but the vertical moves seems preserved. It's important to say that in the forced adduction, the patient presented a free movement of the left eye. So for diagnostic hypothesis,
Let's call someone, Nilva. Let's see.
Okay, Eileen.
Victoria. Oi?
Vitória, great.
Nossa, come on.
Hi, good evening. So for the diagnostic hypothesis, we have this 31-year-old male patient with history of low vision on the left eye since childhood due to ocular toxoplasmosis. And he suffered a blunt trauma in the left eye 1 day ago. As the cornea and the sclera are all intact, and the patient has this closed globe trauma, and also traumatic strabismus that could be secondary to a traumatic lesion in the medial rectus, or a restriction of the lateral rectus muscle, possibly due to this fractured orbital fracture that he suffered. I think that's it.
Okay. Guilherme, you can go on, please.
Yes. So we have a patient with history of toxoplasma retinochoroiditis with a macular scar, which explains the low vision and absence of diplopia, who are presenting a closed globe injury as the cornea and sclera are intact, and are involving with a traumatic strabismus. Strabismus following trauma can happen for several mechanisms, as a lesion in a supranuclear structure or involving nuclear nerves, which is unlikely in our case, as the patient presents only limitation to adduction. So we must think about a lesion in an evolving intraocular muscle. That could be secondary to a muscle involvement in an orbital wall fracture, which is also unlikely in our case, as the forced deduction is normal, and it's very uncommon to have an incarceration of the lateral rectus. So a muscle contusion is possible, and also a traumatic disinsertion or laceration of the medial rectus muscle. So for the management.
Please go on.
Okay, so for the management, we have a clearly surgical case. Our first step was to perform a head and orbits imaging. The CT is the best method to analyze the orbit and the bones. And the MRI would be the best method to analyze the soft tissues. Thinking about the availability in our service, we initially ordered a CT. We also admitted this patient and ordered a pre-op systemic evaluation. So here we have the CT. We can observe this proptosis, and also here pointed in red, although it is not the best method, this CT suggested this laceration of the medial rectus. The central nerve system was normal. Here in this cut, we can observe this fracture of the orbit pointed in yellow, also presence of hemosinus pointed in blue, and presence of gas inside the orbit pointed in red. This patient was also evaluated by the plastic and reconstructive surgeon department, who indicated conservative management for the orbital wall fracture, and also by the ENT department, who indicated a nasal irrigation and antibiotic prophylaxis with amoxicillin for 7 days due to the presence of hemosinus. So we must add here in our diagnostic hypothesis the orbital floor fracture. We also can rule out a lesion in a supranuclear structure or a lesion in oculomotor nuclear nerves. We also can rule out a muscle involvement in an orbital wall fracture. And at this point, our main hypothesis would be a traumatic laceration of the medial rectus muscle of the left eye. So finally, in the OR, it was performed a 360 peritomy. The cornea and sclera were really intact, so a closed globe injury. The medial rectus muscle was identified. That was more or less 10 millimeters of the muscle remaining in the insertion, presenting hematoma, but the muscle was completely lacerated. It was possible to identify the posterior part of the muscle, but the suture was impossible because it was extremely friable. So it was performed a suture between the muscle fascia and the remaining part of the muscle in the insertion. And to maintain the eye in primary gaze, it was performed a suture between the sclera and caruncle. It was also performed a conjunctival suture and insulated topical antibiotics. All the sutures were performed with Vicryl 6O. Here's the picture of the post-operative one, the patient already presenting a good alignment of the eye in primary gaze. Here in the day 20, the patient presenting a good alignment. At this point, it was performed injection of botulinum toxin 6 unities in the lateral rectus of the left eye to avoid contracture. And here in the day 27, the patient presenting a very good alignment of the eyes in primary gaze. In the video, we can see that he's even able to perform some adduction of the left eye, which is kind of hard to explain how, but patient and surgeons very happy and satisfied with the surgical outcome. Thank you.
Nice case, very difficult. Can we hear from Dr. Mauro Plut?
Yes. Can you hear me?
Perfectly.
First of all, I'd like to congratulate Guilherme for the presentation. The presentation is very good and very well documented case. And we have some, first of all, one question. Why was the medial rectus involved? Why was this muscle? I'm asking this because usually the muscle that's more afflicted in a trauma is the inferior rectus because of the bell phenomenon, the bell reflex. When the punch is coming, usually the patient, the person closes the eye and close the eyelid and the eyes go up. And this muscle here, the inferior rectus, is the muscle heated. I have two hypotheses here. One, the patient was looking to the other side, looking to the left and received the punch. Another one is maybe this patient could have a XT and exotropia because it has no vision in this eye due to a macular scar. Okay. Anyway, the result was excellent. Excellent result. I would never expect such a good result in a case like that. Mainly when you look at the CT scan and see that there was a rupture in the muscle belly. Usually, the best surgery for these cases, the best result is when you find the muscle. When you find the muscle, usually, when you have a lesion in the lateral rectus, superior rectus, or inferior rectus, you usually you find the muscle because this muscle, inferior, lateral, and superior, they are attached to the oblique. Superior rectus with the superior oblique, lateral and inferior to the inferior oblique. The medial rectus is a little more tricky to find it because when you lose this muscle, it goes back to the orbit. Go back between aspas. Because in reality, it doesn't go that far because the muscle is attached to the medial orbit by the pulleys, anyway, in the surgery they found the muscle, but they couldn't reattach it to the sclera due to the state of the lesion. Was a very friable muscle that they couldn't do. I have to say something about reoperation in trauma. First of all, these cases should be approached by a strabismus specialist. It's not the case for a regular ophthalmologist or that is not accustomed to deal with muscles. A good tip is to avoid atropine during the anesthesia, because when you don't use atropine, you can look at the cardiac frequency and trying to find the muscle through the cardiac frequency. Okay. In this case, it was a period that couldn't put the muscle back again. But I didn't do this surgery. I spoke with the surgeon, and what happened is the retinal people enter before, and they did a big peritomy, and maybe they have lesion the muscle. This technique of anchoring the muscle to the caruncula, the sclera to the, not the muscle, sorry, the sclera to the caruncula is well known. Very many people do. Some people do anchor the muscle to the pulleys. And the result was very, very good. And how can you explain the adduction of the eye when a muscle that was completely spoiled? No, this could be the word, lesion. What happened is this muscle is not paralyzed, it's not a palsy of the muscle. So this muscle still has strength. And this strength of the muscle is transmitted through the tenous capsule to the intermuscular membrane. It could adduct the eye. Another question here would be, another doubt, if we should recess the antagonist. In cases of palsy, we always do recess the antagonist. In case of lost muscle, I prefer not to recess or put the recession under adjustable suture. I would like to congratulate Guilherme for the very nice presentation. And if anyone could add any comments, we will welcome. Thank you very much for the opportunity to discuss this case.
Guilherme, how long after the trauma was the surgery performed?
1 day.
Oh, it was fast. The day he came to the OR.
Yes.
Okay.
Exactly.
Good service.
Any comments from our colleagues, or should we go on to the first case report from Duke University?
Norma,
Well,
ask anyone.
Yeah, I
Norma.
could certainly comment.
Okay.
I mean, the amount of adduction to me would indicate that that muscle is attached somewhere to that eye, far enough anterior to pull the eye that far in. If that muscle was completely transected, that eye would not go past the midline. It would stop and you would not be able to see that eye. It'd be a -4 adduction. So either it wasn't fully transected and there was some fiber still attached, or the remaining stump was not so far posterior that it wasn't working at all. So it's an outstanding, I don't care. I'd rather be lucky than good. So, you know, it's an outstanding result long-term. But whether you go after the antagonist lateral rectus on the right would only be necessary in a functioning situation where the eye could actually see. I think for cosmetics, you look pretty good where you are. But for the it's the time, I think we can go ahead and move on, if that's okay. First of all, I'd like to thank the Police School of Medicine and the Department of Ophthalmology for allowing us to join you tonight. I say the first two cases were extraordinarily well presented. The videos and the photographs were outstanding, and already learned a little bit about DCRIs that I didn't know before. So thank you for that. We have two pretty interesting cases that we'd like to present. The first is going to be presented by Dr. James Tien, who's a current second-year eye resident at Duke.
Okay, thank you, Dr. Buckley. I'd like to welcome all you folks from Duke as well. It's a pleasure and an honor to have the second jaunt ground rounds with Duke. I would like to mention Dr. Edward Buckley, who just spoke with us as the chairman, if I'm not wrong, of the Department of Ophthalmology at Duke. And to thank Dr. Pratap Challa as well, the chief, the coordinator of the residency, for agreeing last year in having this joint ground round. And as well, I saw in the list here, Sanjay Asrani is a famous colleague from the glaucoma meetings and the American Glaucoma Society. I'd like to welcome Dr. Asrani as well. And I just want to share you my cup from Duke that I got from a fellow who worked with Felipe Medeiros, that is a close friend of us.
Ah, yeah.
And then cheers for Duke. Thank you, guys.
Thank you.
Welcome. Let's see, Dr. Tian, your microphone.
Hello, everyone. Can you hear me?
Yes,
can.
perfectly.
Okay, great. Well, thank you so much, everyone, for the opportunity to present this case presentation. Thank you very much to Dr. Buckley, Dr. O'Derry, and many others who helped make this possible. So without further ado, let's get started. We have a 17-year-old boy who's brought in by his brother for a change in visual behavior for the last 1 or 2 months. Of note, the brother says that this patient is bringing objects closer to his face, no longer playing video games, and also has some mild photophobia. Patient's history is significant for autism spectrum disorder, manifesting with social and sensory delay. He was also born premature at 33 weeks, but reportedly had no ROP. He also has a long-term history of abnormal eye movements, and also has a history of eosinophilic esophagitis. His exam showed markedly decreased vision. His right eye could only see light, and his left eye could only trace the HOTV letters at 6/200. His pupils had no RAPD. His eye pressure and extraocular muscles were unremarkable, and he was unable to participate in visual field or color plate testing. So remember, this vision was tested in a patient that was autistic, nonverbal, and socially uninteractive. Furthermore, we also have no baseline visual acuity. This patient has not seen any eye doctors recently. So especially in this population that it's difficult to test the vision of, I'd like to ask the audience, how would you evaluate his vision?
That's the audience. The audience would be our residents.
No, we don't do that at Duke. We pick on the attendings.
Okay. Let's see.
So the question is, you got this kid who know's got some obvious issues, and what is your kind of strategy in approaching these kind of things, so where you can kind of get some ballpark estimate of what the vision is, kind of good, moderate, or bad? What kind of things do you do or look for to help you in that?
We can have one of the residents. We can have.
Well, let's have. I want an expert. Let's get Dr. Friedman, who's a pediatric ophthalmologist extraordinaire, deals with glaucoma, low vision. Sharon, what do you do to try to? What are your tricks for this kind of thing?
I mean, I think one of the things is you're wondering how. I mean, to me, if a parent says, my child used to be able to find his food and now he's, it depends whether how interactive they are. Sometimes these kids won't do anything for you, but the parent will have a pretty good idea about the functional vision and that it has declined. So things like, does your child feel for his food? Does he eat it? Does he, you can't ask if they know their way around the house because they get this incredible memory for where things are. But, if somebody moves a chair, does he now run into it? In the clinic, I like to use, things like, if it's really light perception, sometimes something as simple as you have light projection, can you put a flashlight in different visual fields? I have this big Ocan pattern, not really a drum. It's hard to ignore it if you can see it at all. And so you can use, okay and response. You can use lighted or moving toys that don't make any noise. You have to be careful because these kids are good at scanning. And then, of course, you can do optotypes, but I think it's pretty clear, although somebody put that he traced something, and I missed that, James. I'm sorry, whether it was 6 inches or what it was, because you said trace an HOTV card, traces on the card at 6, so that would be 6/200. So the 200 size, which I think is about the size of our card that we match with, at about 6 feet away. I'm guessing that's what they did. And I hate count fingers. My residents know I hate count fingers. I say, what color finger, what background? So I do think that anything you can get and optotype-wise like this is helpful, but I often think that the story and what you see, sometimes I'll reach out my hand to the kid, see if he'll reach for my hand in different fields of, different visual fields. It does that, it's different quadrants. So very, and then the key issue is change. So.
Yep. Great. Okay, let's go move on.
Thank you so much for those excellent strategies. I'd actually also like to show a video of his nystagmus, of his abnormal eye movements. Apologies.
Okay, look toward my finger.
You can see there's some right beating nystagmus, some left beating, some intermittent cetodes, and they're essentially horizontal in all directions of gaze.
Then hold your lid. Look down this way. Look down this way.
And his strabismus exam was also was grossly ortho in all directions. And there is his cycloplegic refraction that doesn't really provide any explanation. And his anterior slit lamp exam was also completely unremarkable. Here's a picture of his fundus bilaterally. As you can see, the peripheral retina, the vessels, all those look pretty unremarkable. And then the nerves, when we zoom in and look closer, there's no signs of swelling, there's no heme, there's some, slight temporal, pallor in both eyes. But when
don't go back there for a second. Dr. Boulvare, when you look at this, what jumps out at you?
So what I see is that there is definitely some temporal pallor of both optic nerves. There's no swelling, but temporally, especially in the left eye, there's some pallor.
And so, Dr. Alderi, what would you expect to see on OCT in the optic nerves that look like this?
The OCT, so good question. So are we looking at the average retinal nerve fiber layer? Are we looking at the macula? If we're thinking the average retinal nerve fiber layer, this could look normal or maybe a slight thinning of the temporal retinal nerve fiber layer.
So let me ask you this. His vision is 6/200 maybe in one eye only and light perception or something. Does this look like that kind of nerve? I mean, would you expect the vision to be that poor looking at these nerves?
No.
Yeah. How about you?
It's very acute.
How about you, Dr. Boulvare? Does that resonate with you either?
Well, unless there's a clear central scotoma, sometimes the nerves can look pretty good with just temporal pallor, but the central scotoma can be pretty dense.
All right, Dr. Tian.
All right, so we did get the OCT of the RNFL, and contrary to our expectations, the temporal quadrant looked pretty full to us. There's a good segmentation, good tracing of that nerve. But then when we looked at the macula, that perhaps showed a little bit more abnormality. As you can see, there's a significant underdevelopment of the foveal architecture. So at this, both scans are best through the fovea as we could find. So at this point, we diagnosed this patient with foveal hypoplasia of both eyes, and that abnormal eye movements can be called infantile nystagmus with sensory deficits. But what about his recent subacute vision loss? As we mentioned before, that nerve appearance does not explain necessarily light perception vision, for example, in the right eye. And he was, according to the history, able to even play video games up until about a month or two ago. And there was nothing on the anterior segment, no active appearing retina pathology or RNFL thinning to explain. At this point, I'd like to ask the audience what they think could be causing this.
So before you get that, I'd like Dr. Jaffe to just sort of comment. Did that macula OCT, did that look like an acute issue, or did that look like something that may explain why he doesn't see well since he was a baby?
Oh, that does not look like an acute thing. I mean, it looks like foveal hypoplasia to me, and that's not something that comes on suddenly.
And the optic nerve didn't look acute either, did it, Dr. Boulere?
No, but remember that the optic nerve takes a couple of months before we start seeing some changes. So if it was, I don't know when he started complaining about his vision or when people started noticing some vision changes, but if it's recent, what we're seeing by looking at the optic nerve might not be accurate. So it doesn't mean that the optic nerve is actually working.
Okay, good. All right. Sorry to interrupt there, James.
Absolutely. And also, all right. So actually, we'll bring it back to the audience to see if they have anything on the differential so far.
Can we talk a little bit about what level of acuity you would expect if the patient had a simple foveal hypoplasia?
Yeah, my experience, we see a lot of that in kids, is that it's usually around 20/60, 20/70, could be as bad as
20/80, yeah, exactly.
Yeah, right. So far, I don't have a good explanation for the bad vision this kid has. There's nothing in the optic nerve exam. There's nothing in the retinal exam that would explain why this kid should be so poor in his vision. But let's see what happens.
All
So
right.
thoughts on this?
I do have some ideas, but I don't know if you want me to say anything.
Well, not yet. You know too much.
There is a question from the audience. Is the patient under any medication?
No. I think he was taking maybe something for his esophagitis.
Oh, okay. His eosinophilic.
And with that degree of temporal pallor, particularly in the left eye, wouldn't you expect nerve fiber layer thinning?
Yeah, absolutely would. That's why the OCT doesn't resonate with me with regards to that temporal pallor. There seems to be a disconnect. So
right. So the only thing that could make the nerve fiber layer a normal thickness would be some sort of relatively recent trauma and axonal swelling. So I'm thinking that there might be an overlay of a recent optic neuropathy.
correct. So go ahead and give us a differential there, James. We need to move
Absolutely.
on.
So, I think we've focusing on the optic nerve appropriately here, and a variety of things can cause that temporal pallor and the vision loss. We think of a compressive or an infiltrative process. For bilateral disease, we especially think of toxic and nutritional optic neuropathy. You can also think of Weber's hereditary optic neuropathy. Then actually, the diagnosis that the referring pediatric ophthalmologist had settled on was non-organic vision loss. But I know based on our discussion, that's not what we think it is so far. But I'd actually like to ask, there's actually a specific workup that's recommended specifically by this patient's history. I'd like to ask the audience if there's anything here that they think would suggest a specific workup.
Go ahead and fill them in.
All right. So it's actually his autism and his abnormal eye movements. So what happens a lot of times in autism is that the people suffering have extreme sensory sensitivity, and that's often why they resort to familiar repetitive behaviors. But that sensitivity also applies to the food that they eat. If you will take this quote from an adult with high functioning autism, canned asparagus was intolerable due to its slimy texture, and I didn't eat tomatoes for a year after a cherry tomato burst in my mouth. The sensory stimulation of having that small piece of fruit explode in my mouth was too much to bear, and I was not going to take any chances of that happening again. So upon further questioning, this patient pretty much just ate fries and chicken nuggets and did not eat a healthy diet. He was a very picky eater, and his BMI was of the 7th percentile. This is such an association of not just the association between autism and nutritional deficiencies that can cause vision loss, but also the association between poor baseline vision and autism. It's thought that, you know, when kids have poor baseline vision, they're not able to visualize nonverbal cues, and thus that plays a role in their poor development of social behavior as well. And patients with poor baseline vision can be even more severely affected with more severe vision loss. So we did a workup of the MRI brain and orbits to look for compressive infiltrative process. It was unremarkable, and a heavy metal screen was also unremarkable. But then we did the nutritional workup, and we found severely reduced folate, vitamin A, and actually copper as well. Copper is actually a cause of, kind of rare cause of a myelooptic neuropathy, just to keep that on the differential. So all we did was ask the PCP to treat him with a multivitamin supplementation. After a month, remember his vision was previously light perception in his right eye and 6/200 in his left eye, and it improved to 20/150 in both eyes. He was still unable to participate in color vision testing, but his visual fields were now full. 3 months later, his vision continued to improve. He began to regain some color vision back, but then the optic nerves appeared to have significantly more temporal power. And here's a more updated photo about 3 months after presentation. And I think we can all agree that both eyes, especially that left, definitely shows more temporal power. There's an RNFL showing temporal thinning. It's now 31 and 39 in each of those quadrants. So now I'd like to ask the audience, why did he develop RNFL thinning 3 months later after we had corrected the vitamin deficiencies?
Yeah, so the interesting thing here is as his vision got better, his clinical picture got worse. His optic pallor was worse and his OCT was worse. So thoughts on why that could happen?
Was it swollen in the beginning and was covered up?
That's honestly probably one of the two main explanations we have.
We've seen that actually in some patients with ocular inflammation that have had swelling of the optic nerve, and then when everything is treated, they actually start looking worse with more optic nerve thinning.
Absolutely. Yeah. So if the swelling perhaps was not significant enough to be notable on exam, and then also as previously mentioned that there's a delay between the function and then the structure that we see on the OCT. So do not be fooled by just a normal appearing full RNFL. So just a couple more details about nutritional optic neuropathy. It classically presents with bilateral decreased visual acuity and central or cetrocentric stromas. There's often color vision loss and temporal pallor. The most commonly associated vitamins are B1, B9, and B12. And the thought that the loss of those important cofactors can cause accumulation of toxic byproducts and cause depletion of ATP and optic nerve death. To especially keep in mind these specific at-risk populations, children with autism, of course, also with cystic fibrosis, and also with a variety of eating disorders, different milk formulas or other gastrointestinal issues, methotrexate use for its effect on folate, and then of course adults with gastric bypass or who are vegan. So just to summarize, be sure to keep in mind nutritional optic neuropathy when a patient presents to you with vision loss. It's not the first thing that pops into mind to go send a nutrition panel when we're evaluating vision loss, but especially in these vulnerable populations, please keep this in mind. So thank you very much to Dr. Buckley, Dr. Derry, and Dr. White.
Nice job, James. I'd like to ask May's question. That's a remarkable increase in vision. I mean, how often do you see that?
This is the first case of nutritional we actually caught at time. Or this is the fastest case of nutritional that was referred to us. So I've never seen it improve that much. We've had a few cases by the time they got to us, they were already NLP and they just never recovered. It was very heartbreaking. But yeah, it's atypical for us to see this much recovery of the vision. And I think the reason why he recovered is we checked for vitamin deficiency before the pallor was obvious, which the current academy recommendation is to check for it once you see pallor. So it's an alerting. This case is to alert that, hey, if you have an autistic kid with unexplained vision loss, start with vitamins.
And Terry brought up an interesting point in the comment, Terry Simcheshin, about could the vitamin A deficiency have contributed to more dry eye type symptoms initially, and so that's why you see such a remarkable improvement in vision with supplementation.
So I do make a point to check for dry eyes in case it's one of my pet peeves. We didn't have any dry eyes. But the typical scenario with vitamin A is they do come in with severe dry eyes.
Maze, you need to get closer to the microphone. You sound like you're in an echo chamber.
Oh, I'm sorry. I'm using headphones. My computer is breaking down. I ordered a new one. I don't have it yet.
Hey, guys, a great case. With regards to the false positive OCT, the green disease OCT that was shown in the beginning of the case, I also believe it was due to probably to early edema of the RNFL. It's a possible explanation.
Actually, there's something very tricky about that false positive OCT. So if we go back to the fovea scan, I don't know if James can show it again. We can see that he had ganglion cell thinning, but it wasn't easy to recognize that he had ganglion cell thinning because of the foveal hypoplasia. But the ganglion cell layer is supposed to be at least the thickness of the INL, and we barely see it.
Okay, that's a great case. Very difficult.
All right, Dr. Chali, you're up.
Yep, thank you very much. I'd like to go ahead and introduce our next speaker. Hesham Gabber will be presenting our second case for tonight. He is one of our senior residents here, and Hesham, I'm going to let you should be able to share your screen. And he's going to present a case to us called Awakening the Beast.
Can you see my screen now, and can you hear me?
Yes.
All right. Good evening, everyone. This is Hesham Gabra, one of the third-year residents at Duke Eye Center. It's a great pleasure and honor to present at this great meeting. My case today is about awakening the beast inside the eye. So let's see how this happened. We have a 67-year-old male presented 2 months after intravitreal steroid injection for cystoid macular edema secondary to a branch retinal vein occlusion in the right eye. Patient was referred for evaluation of worsening vision in the right eye of 2 months duration after the last intravitreal steroid injection. Associated symptoms: a 6 months history of photophobia, eye injection with recurrent flares every 2 months, worse over the last 2 months after the last steroid injection. Review of systems, pulse for tick bite, which was unclear when.
So Hesham, should we? Well, go ahead. Okay, we'll ask.
Yeah, so patient was referred to Duke, and he was already on Pred-40 QID in the right eye and atropine QHS in the right eye. Past history: he has cataract surgery, uneventful cataract surgery in 2012, about 7 years or 8 years before presentation, and branch retinal vein occlusion in the right eye since 2015. Has been receiving multiple intravitreal anti-VEGF injections, but recently he had the last injection was intravitreal steroid. Medical history is hyperthyroidism treated with radiation, hepatitis B, skin cancer, and UTI. Family history is positive for mother who had lupus and hepatitis C virus. On examination, visual acuity in the right eye is counting finger at 3 feet. Vision before symptoms onset was 2200 due to chronic CME from branch retinal vein occlusion. Pupil is dilated, IOP is 11, EOM and confrontational visual field is normal. Left eye examination was overall normal. Right eye congens sclera 2+ injection, cornea was mild endothelial haze, anterior chamber with 3+ cell and no flare. Iris is normal. Lens, there is a IOL in bag, and vitreous with 1+ haze and 2+ cell. Left eye exam is normal.
So let's ask Dr. Jaffe what his thoughts are at this point. 2 months after an intravitreal injection, has a few cells in the anterior chamber. Dr. Jaffe? So
I'd at least be thinking of, a delayed endophthalmitis, whether it's infectious or be unlikely to be non-infectious at this far out. But so that'd be one thing related to the injection. You had a tick bite, could that be Lyme disease? It doesn't look like Lyme disease, and unless you had a history of a target lesion, that would be at least unlikely. In the COVID times, everybody wants to know if there could be activation of inflammation related to COVID vaccine. And that's still being debated as to how often that actually occurs, although it probably does occur in some cases, but those are some of the things I'd be thinking about.
All right.
Thank you.
Thank you. And this is a fundus examination. You can see in the right eye optus photo with the vitreous haze mainly over the central area. And in the periphery, we cannot see any evidence of retinitis or vasculitis, although the view is still hazy. Left eye is normal.
What I would mention is I didn't give the whole differential for posterior uveitis. I mean, in the back of your mind, you're always thinking, could this be an endogenous uveitis that's not related to any of the external things that I was talking about?
Thank you. We obtained fundus fluorescein angiography, and we can see in the early frames still with the vitreous haze and optic disc leakage, and there is no evidence of any vascular leakage at this point. Late frames with still the hot optic disc and no late leakage. Left eye is normal. OCT was unable to obtain the right eye and normal in the left eye. Then we proceeded with lab workup, as Dr. Jaffe was discussing about uveitis. So we had negative CBC, CMP, chest X-ray, angiotensin converting enzyme was within normal, quantiferon gold negative, HLA B27 is negative, syphilis was negative. So at this point,
I think I see Dr. Toth on here, at least I thought I did. Cindy, your thoughts here? If not, we'll go back to Glenn, since I have a limited view of who's on the screen.
I think there are some other retina colleagues on the line. I don't know if they're too afraid to say anything or not.
I think Dr. Ladd is on the line.
So ask Nora, any thoughts here?
I don't know about Dilraj.
Sure. So I am familiar with this case, but
no wonder you
in general, if you're considering an infection, that is the line that you want to pursue first whenever you're considering dealing with chronic inflammation. So I do agree that the next step would be to treat for a possible infection and at the same time obtain a sample, whether that's taking an aqueous or a vitreous sample, and send it off for culture.
Now, this was a 2-month course, right? So what kind of infections are you thinking about with a 2-month course?
So an indolent course like that, either you're concerned about, it's clearly something that's not very virulent, not very aggressive. So it could either be a chronic fungal infection, in which case you would consider endogenous as well, and then you would pursue that line of workup. But in pseudophakic patients, particularly, we know that there's the ability of anaerobic organisms to sequester in the capsular bag, and that can also be a source of, inflammation and resistant infection. So that needs to be evaluated as well. And when you're considering organisms like that and taking a sample from the eye, you want to instruct the lab to to let the culture grow out for at least 10 days to 2 weeks.
Dr. Tavares had his hand up.
Yes, thanks. I have a question for a glaucoma specialist. We have seen here and have read about chronic inflammation and sometimes elevated IOP as well, due to the silicone droplets from the syringes used for anti-VEGF injections. Is that possible? It's from a glaucoma guy. Sorry for the question.
It is possible, but it would be a dose-dependent fashion. So depend on how much of the trabecular meshwork is blocked by the silicone particles. So it'd have to be someone that, because you get such a small volume of them in the syringes, that it'd have to be somebody that already has very poor outflow, meaning very advanced glaucoma. And so those can be, rarely can tip them over. But what we do see, silicone particles from silicone oil in the back of the eye, they get emulsified and come forward. And we've seen that, but it's a dose-dependent phenomenon.
And I think it would be unlikely to cause that type of inflammation with such a degree of vitreous opacity as well. I was just going to make one general comment about when you do diagnostic vitrectomy or a diagnostic tap. And typically it's when you've done your laboratory evaluation, as Hashim had done, and then there's diagnostic uncertainty, either because you've given empirical treatment and they didn't respond to the empirical treatment for your most likely diagnosis, or when you suspect infection or cancer, that especially for suspected cancer. But if you suspect infection, obviously that's the other reason to do it.
All right.
Okay, I think we helped answer that question. Yep.
Right, so we decided to go for diagnostic parsplenic vitrectomy with the injection of vancomycin and ceftazidime. Post-operative day 1, vision improved to 20, clear vitreous and no evidence of retinitis or vasculitis. OCT as a chronic CME and ERM. Vitreous tap results were negative for malignancy, fungus, acid-fast bacilli, viral CMV, simplex, and varicella zoster PCR, and bacterial culture. Post-op week 1, patient is happy, visual acuity is steady. Now with temporal capsular plaque behind the iris, AC is quiet, vitreous is clear, retina with no signs of inflammation. Month 1 after surgery, patient presented with worsening vision in the right eye, and he's already on pred-40 6 times a day. Exam with visual acuity worse from 2040 to 2080. AC was 2+ cell, capsular plaque temporally, vitreous was 2+ cell, retina has no signs of retinitis.
Can you describe the capsular plaque to us?
Mm-hmm.
Can you describe the capsular plaque to us? What did it look like? What color?
It's a white intracapsular plaque. Usually it's a sequestered organisms inside the capsular bag.
Okay.
We have a picture of this one later in the presentation.
Oh, okay. Sorry.
Yeah, sure. OCT with ERM and hyperreflective foci, still with the CME. So at this point, we had a high suspicion for P. acne, and the patient was offered the IR removal, but he declined. So, and we decided to go ahead for intravitreal injection of vancomycin. Vision and symptoms improved initially. 3 weeks later, symptom recurred. Patient started to complain of photophobia, but vision was stable. Eye drops, he's on pred-40 6 times a day. Exam was a vision 2064, AC was 2+ cell, vitreous 2+ cell, persistent, capsular plaque temporally. OCT was the ERM and CME. So at this point, the decision was to go for parsplenic vitrectomy, capsulectomy, IOL explantation, and intravitreal vancomycin for the infection and Avastin for CME. Repeat culture at this point revealed the P. acne after 6 days of culture, and this is what talking about, that this organism might be very slowly growing in culture and might need a few days, many days to grow in culture.
So before you move on, can I ask Alan Carlson, who was on, is there an appearance of a, I mean, we get plaques on the back of remaining posterior capsules all the time. Is there anything about the appearance of the plaque that might tell you that we're dealing with an infection as opposed to just the natural result of capsular removal that we get from cataract surgery? I guess he's.
I can make a comment if they didn't. I've seen more. Often you'll get a little bit of a fluffy appearance to it, but you also can have small punctate white opacities adjacent to it that are almost like little satellite lesions, and sometimes that can also be the clue. And it's all when you ask. Often it is hidden partially by the iris, and you really need to have the patient look to one side or the other to see it. They may be surrounding they're often around the loops of the IOL where at the junction or the haptic, whatever you want to call them, where the loop or haptic is adjacent to the optic. Often you'll find a site at that location.
Is that more common in 3-piece IOLs as opposed to a solid IOL, 1-piece?
I've seen it more commonly in 3-piece, but I don't know if that's just because I'm old.
Well, no, I guess where I was coming from, 3-piece, you have a junction where you're talking about with the optic and the haptic, whereas in a 1-piece, it's a continuum. And so there will be no reason to focus in one area versus another, I would think.
Yeah, it's a good question. I don't know the answer. But it does get at what we were talking about before, and that it's not that delayed infection is not that uncommon after, for example, the intravitreal injection or after cataract surgery. We reported, I think, the very first case of P. acnes many years ago, about 9 months after cataract extraction. So it can be very delayed.
And there Dr. Asrani raised his hand.
Yes, hi. Can you hear me?
Yes.
Yes.
Yes, the 3-piece IOL, Ed, is certainly more susceptible to infections because the haptics are made of proline, and the proline has a much higher affinity if it touches the conjunctiva while it is going in to attract bacteria. Whereas if it is completely made of acrylic, then the chances are much less.
Gotcha, thanks. All right, continue on.
All right, over the next few months after the surgery, there was a low-grade inflammation treated with topical steroid, and best corrected version was 2050 with a +11 lens. OCT, clear vitreous, ERM, still is a CME. So later, patient underwent partial vitrectomy, ERM peeling, and secondary IOL implantation, and has been receiving intravitreal Avastin injection for CME.
What's the time course? How long after the initial surgery, and how long should you wait? Glenn,
surgery was about 1 year. Yeah, okay. I mean the final surgery, the vitrectomy, RM peel, and secondary IOL, I think it was around 10, 11 months after the first.
Sorry, was the question that when should you place a secondary IOL?
Right. How long should you wait?
Yeah. How long should you wait?
You don't have to wait. Some people may do it concurrently.
And I personally like to make sure that the eye is not inflamed prior to doing the procedure. So I would wait until after the initial procedure, when you took out the bag and everything else, I would wait till the eye is quiet. And after that point, I agree with Dilraj. I don't see why you need to wait, but I at least like to do it after the eye is quiet. I don't want to do it when the eye is still on. So I would treat aggressively to get the inflammation quieted in the period after the original capsulectomy, removal of the IOL, etc., to get the eye quiet quickly. But after that, I don't think you have to wait. You have already removed the source of the infection.
Do you have to remove the whole plaque, or just get the IOL out of there?
Well, you need to remove the plaque. I mean, to me, that's the most important part of it. I have done a few cases where, as in this one, where the patient didn't want the IOL removed, or they at least wanted to try to do a partial procedure. And I have, when there is enough capsular support, I removed the plaque itself without removing the IOL. And I've actually had a couple of patients who have not needed anything further. So that can work, although I would say most of the time you need to do what was done here.
And when you remove the plaque, you're using a Victrector to get it out of there?
Yeah.
Aren't you spreading things around as you nibble on this thing?
Well, you're aspirating as you're sucking. You're not just nibbling and blowing stuff around. You've got suction on the capsule as you're cutting.
Oh yeah, but you got infusion keeping things whole, so that's spreading things around too, I would think.
Yeah, that usually isn't so much of a problem because you're right up against the capsule, aspirating and cutting at the same time. And if there are particles that are getting into the vitreous, you're going to be lavaging it anyways by the rest of the vitrectomy and as the irrigation fluid goes in. So, and you may have, if you're taking the IOL out, you've taken out the scaffolding. So it usually has not been a problem. Plus you're going to inject antibiotics at the end of the case.
Go ahead.
Right, so this is post-op month 2. There are no complaints. Visual acuity 20/40. AC and vitreous are quiet, and OCT was markedly improved for and dry macula. So this is just a brief overview of Cutibacterium or P. acne. The more recent name is Cutibacterium acne or C. acne. Endophthalmitis, it's a normal bacterial flora found in the skin, conjunctiva, oral cavity, external ear canal. It's an anaerobic gram-positive bacillus with slow growth on culture media. It's the most common cause of delayed post-op endophthalmitis following cataract surgery. The longest reported time interval is 20 years from the time of surgery. And in our case, symptoms started 7 years after cataract surgery. Diagnosis is basically a white intracapsular plaque in the setting of delayed onset mild to moderate intraocular inflammation after cataract surgery. As we can see here, this is the white plaque. Capsular plaques are composed of sequestered organisms inside the peripheral capsular bag. Definitive diagnosis with culture of AC or vitreous TAP. PCR might be needed as the organism is difficult to culture with slow growth. So management, there are 2 main studies that discussed the different treatment modalities of P. acne endophthalmitis. Both of them showed overall similar results. So for intravitreal vancomycin alone, there's a 50 to 100% recurrence as occurred in this case. If you are going to do intravitreal vancomycin with partial planar vitrectomy, there's a 50% recurrence. For the third option is intravitreal vancomycin, partial planar vitrectomy, and partial capsulectomy. And there's a 14 to 50% recurrence rate in this treatment modality. And the definitive treatment is the intravitreal vancomycin vitrectomy IR removal, total capsulectomy, and this is 0% recurrence. So back to our case, our patient most likely developed delayed onset endophthalmitis that was triggered by the recent intravitreal steroid injection, which basically awakened the P. acne organism inside the eye. So we think that this happened because the steroid suppressed the local ocular defense mechanism against the inoculated P. acne during or following the previous cataract surgery. While P. acne endophthalmitis is classically described after cataract surgery, there are case reports of P. acne endophthalmitis after partial planar vitrectomy and even YAG laser capsulotomy. In our case, it's also possible that P. acne was introduced intraocularly during the intravitreal steroid injection procedure itself, not during the cataract extraction. Home message: keep a high index of suspicion for P. acne in patients with delayed post-operative persistent or recurrent inflammation. Intravitreal antibiotics injection is inadequate. Partial planar vitrectomy with total capsulectomy and IOL exchange is a definitive treatment. So I would like to thank Dr. Grewal, Dr. Challa, and Dr. Buckley for their help with this presentation. Thank you.
Thank you.
Thank you, Hesham. Very nice. So the floor is open for questions. There was one question here, no KP. Is that correct?
There was an endothelial haze. There is like the KPs was not mentioned on the exam.
Okay.
Dr. Alaman had her hand up.
No, I did not. It was just.
Sorry.
Sorry, I'm wrong. It's just saying I like the cases very much. They are very well prepared. I liked your approach also to call the attendees. We are going to do that.
Well, the logic is that you've got all these very bright people in the room,
yeah,
and you might as well get their insight into the case and how they think about it, and what's important to them. You can't read this stuff in books. You have to see it play out. And so we spent a little time. They're not prescripted. They have no clue about what's coming, and as you can tell, you get some very interesting pieces of information that are really helpful in taking care of patients going forward. So it takes a little heat off the residents.
Yeah.
Yes, we should adopt this here as well. It's a good idea.
But we usually have
we
usually have one faculty member who knows what's going on, is responsible for moderating, and they are the ones that call on the various people so they get the right answers. Yeah.
Yes, we know that. Our residents do that as well.
Well, thank you all very much. This was a very good
Thank you.
session. Learned a lot. Appreciate everybody's attendance, and look forward to doing this again.
It was
For
an
sure.
honor to have you all your departments. Thank you very much.
Thanks. Yeah, thank you.
All
It's
right.
wonderful. Thanks.
Thank you.
Thank you. Good night.
All right,
Thank
folks.
you.
Have a good night.
Good
Stay
night.
safe
Good
out
night.
there.
You
You
too.
guys too. Thanks.
You too. Bye.